1 o'clock on what day is it? March 28th, Friday. And we are continuing with our discussion around freestanding birth centers, S18. And we have with us, lucky us, we have the bill sponsor from the Senate. So welcome, Senator.
Thank you, Madam Chair. Thanks for having me, committee. I really appreciate you welcoming me in to talk a little bit about this bill that is near and dear to my heart for sure. I'll start by saying that this passed out of our committee 5-0-0, and then I'm also in the Finance Committee and passed out of our Finance Committee 7-0-0. On the floor, I received no pushback, no questions, and it passed unanimously. So it is very, I think, well supported in the Senate, and folks are really excited about the prospect. So I just wanted to share that with you. I think you all know what a freestanding birth center is. It is a birth center that is not a hospital and is its own facility where typically midwives will work in a midwifery and a wellness model. So it's a much more sort of hands-on approach to birthing, and it feels more like a home than a medical facility, which, as someone who has given birth a couple times, I can really relate to that. And when I had my kids in the late 90s, I live in Chittenden County. There was no freestanding birth center, so I wasn't really comfortable with a home birth, so I ended up in the hospital. And my first birth, it's interesting, in 97, there was a birth center in the hospital. And then by the time 99 rolled around, it was gone. And I think one of the reasons why it was gone was because it just wasn't a big money generator for the hospital. So that was something that I experienced. It was a very different experience in 97 from 99, I can tell you. And I couldn't wait to get home in 99. So I already talked about birth centers are run by midwives, certified midwives. Both of those professions have full licensure and the ability to practice home birth and hospital birth in Vermont. And folks who choose a birth center may also receive prenatal and postnatal care from the providers who work there, which is also really lovely. Freestanding birth centers are a well-established and a highly recommended model for pregnant people. The White House blueprint for addressing the maternal health crisis cites increasing freestanding birth centers as a really important action item. And the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, and the Society for Maternal and Fetal Medicine all endorse the birth center model of care as a safe and evidence-based option for low-risk people. Birth centers are a way for Vermont to improve access and quality care. And as you all know, that is what we've been working on, right? And that's what we're going to continue to work on, improving access and quality of care and lowering costs. These are three critically important things right now. And we all know that. That's what we're working on. So they give pregnant individuals the option, certainly not the requirement, to give birth in a facility that's not their home, but not a hospital. It's a wonderful option. We're one of only a few states that don't allow freestanding birth centers. Not having a freestanding birth center, you may have heard, is resulting in a loss of workforce as midwives are leaving to go work in other states. And I can tell you, in my Finance Committee, when I brought this point up, one of my colleagues in the Senate said, right there, that's a reason to have birth centers. We are losing people to go to other states to work and to give birth. Not okay. We need to keep them in Vermont. That is so urgent right now. And you probably also heard that we're one of only 8 states that doesn't have a freestanding birth center. It provides a low-cost option to folks and will save Medicaid money. That's very compelling. Our largest insurance company shared, and I think I saw this document here, that a vaginal birth at UVMMC is $17,100, and in a freestanding birth center, it's $2,870. So very, very large difference in cost. So better health outcomes and lower costs, especially for historically marginalized and vulnerable folks. Again, this is what we're working on. Some claim, and this was also something that was really important for folks in my body to hear, some claim that the freestanding birth centers will threaten the financial well-being of hospital maternity units. There's simply no evidence of that. And, birth centers typically work in concert, in cooperation with hospitals. And what people in the Senate found really, really compelling was some data that I shared with them around, particularly, we looked at Brattleboro Memorial Hospital. And we looked at how, if you look at the data on this chart, and this, by the way, if you want to dig into it, is the 2022 vital statistics from the Agency of Human Services. So I would recommend that you take a look at that. If you look at Brattleboro Memorial Hospital, you see they did 173 deliveries from within their local area. They did a total of 271 deliveries. Then if you expand out to their entire catchment area, you see that there were 323 births, meaning that 150 deliveries didn't occur in the hospital. So we're talking about 53% of births that they only did 53% of births in their catchment area. So you can imagine that a birth center could capture those people who weren't in the hospital, either at having home births or going out of state. Really important thing to understand, because that was an issue for some folks. That really clarified. And like I said, we didn't get any questions on the floor because I had spoken with a few people who had concerns ahead of time, and that really allayed their fears. So I think you've probably done a section by section. We heard from a lot of people in our committee. I would recommend that you do the same. My conclusion was simply that we're working hard in health and welfare, as I know you are, to make meaningful change in our healthcare system by increasing quality of care and expanding access, all while reducing costs and providing care close to home, and making that care less invasive and less intense. And that is what this bill does. So I thank you for having me today. If you have any questions, I'm happy to try to answer some.
Anyone have any questions for? Is it?
I got a concern and a question.
Yeah.
One of my concerns is we have no idea where this will be located. And if there is emergencies in a birth, getting them to the nearest hospital, that's a concern of mine. And the other thing is, when you talk about a birth center, how many births are you going to be able to do at a time? You don't say you're going to have your baby Monday, Tuesday, or you could have quite a few in there.
Right.
So what size of a birth center are we looking at, or any of that?
I would suggest you take testimony on that, because I am certainly not an expert. Sadly, I never got to give birth in a birth center because we didn't have one. But I will say that my understanding is that, as I said in the testimony, that these birth centers are really going to be there for folks who are healthy and are most likely to have an uncomplicated birth. They do have plans. So there are safety plans typically in place. And remember, these are healthcare providers that are in the birth centers. They are trained. They've gone to school. They have experience dealing with emergencies. So think about a home birth as, we've got a lot of home births in the state and in the outlying states. So this is safer and will deliver better outcomes in the end. I hear your concern. Yeah.
No problem.
Okay. All right. Thank you. I think Brian also had it.
Yeah, I have a question, and it might be better answered by the professionals who would be working in these facilities, but I have to leave in a minute, so I'll ask it now. And then if someone says it after I leave, I can get the answer later. But when birthing centers in other states are not being used for active birthing, are they used for practicing for birth? Things like, in other words, like, one of the concerns we might hear is, there's gonna be this infrastructure that only gets used like once every week or two, because I don't know what the birth rate is. I don't know if there's like every day there's babies in Vermont coming. Yes, but is the birthing center gonna have all those babies there? Probably not. So, but in between, is it used for practicing for birth? Is it used for aftercare with
I think that's a
mothers?
great, I think
Yeah.
that's a great
Or could it
question.
be, like, could it be part of the
Because-
system of care where it serves sort of like a function for the mother and child?
I think it's a great question, Representative Chena. And as I think I may have mentioned, but I'll say it again. There is the option for prenatal and postnatal, so perinatal care in that facility for sure. And I would imagine the facility could be used for birthing classes. I mean, I know I took a birthing class. I live in Burlington. I had to drive to Richmond for the class. So having a space for that would be wonderful. I'm just making that up, but the perinatal care absolutely would be part and parcel. I also I forgot to mention, and I apologize, but a very important provision in the bill is to make sure that there is that we don't require certificates of need. And I know that is something that will probably come up. But, birth centers, as I mentioned earlier, they are not huge money makers, and they are often the labor of love. And certificates of need simply put on a burden that is insurmountable for birth centers. So I highly recommend that you look closely at the certificates of need and make a provision that will not require certificates of need for birth centers. It's really important.
Thank you. And I have a feeling you might be summoned, so I'm going to let you go. I can see outside.
Oh, great. I will go and thank you very much. Yeah, appreciate that. Yeah, we are
Thank you.
doing some stuff down there.
You will find out when you open the door, I think. Now, here it is.
Does she have a handler?
I know that they're doing some things in finance. All right, great. So let's move on to, oh, yes, of course.
I got a couple of questions. A birth center that we're thinking about doing, is this going to be a private owned birth centers, or are these going to be state owned, or?
No, I feel confident in saying right now they will not be state owned. But I think that's a better question for some of the nurse midwives that we have coming up. And would you hold your question and ask them?
Sure.
I have you, Erin, I see it's on the screen, but I have you as Rin on the schedule.
Either one is fine. Erin is my legal name. Rin is a nickname. Either one is fine.
Well, thank you, and thanks for joining us.
Thank you. And sorry I'm coming in as a talking head and not in person. Between 24-hour shifts and getting to Montpelier was a challenge today. My name is Erin Mandeville. I am a certified nurse midwife. I've been a midwife for coming up on 20 years. I started actually as a home birth midwife in Alaska. I was born and raised in Vermont, and I've worked in birth centers in Alaska, and I helped start one in India and worked in Central America, and then in a big tertiary Harvard affiliated hospital. And so I've seen all the settings, and I was excited to come back to Vermont, and knew that Vermont didn't have licensure and a legal pathway to form a birth center, and decided to come here anyway. I currently work at Copley Hospital and CVMC, and also the women's prison up in Chittenden County. But yeah, I just decided, okay, well, we'll fix that. We'll get birth centers in Vermont. If I'm moving there, I'll help fix that. I'm going to talk a little bit about, I know you've heard a lot of testimony yesterday, and then just before me as well. I'm going to try to really address just the equity issues involved in birth centers, and then I'm not sure if it's appropriate. I have answers to some of the questions that were just asked, but I don't know if that's how I should spend.
If you can answer any of them, feel free to put that in.
Okay, I could do that really quickly. So generally, freestanding birth centers are not owned by states. They're independently owned and run by midwives or a group of midwives generally. They are true. I mean, saying they're not really big moneymakers is the understatement. They're not moneymakers. It is 100% a labor of love, no pun intended, or maybe pun intended. But they, and in terms of capacity, so it's even the busiest birth center that I worked at in Fairbanks, Alaska, and we did somewhere between 15 to 20 babies a month, which is really busy for a freestanding birth center. Most birth centers do like 5 or 4 to 8 babies a month. There are usually only like 2 birth rooms, and most of them will have clinic, treatment rooms like for prenatals and postpartum care. Some of them will have a family room that can be used as a classroom, a little kitchen for birth, support members and family to make a cup of coffee or whatever they need. But they're small. They're often in like a house that gets converted, or for some reason in Alaska, strip malls. But that's just Alaska. But they're small operations. I feel like there was, I found the question about what do we do when they're empty really fascinating. Would there be, capacity to practice or whatever? And the thing I thought about that is, so it's being run as a clinic even when no one's in labor. So it isn't, they're generally not empty that often in that sense. But there's also, this is happening in Boston and Massachusetts and other places where residents, so if you say like you have an academic medical center such as UVM or other residents who are going through their obstetrics rotation could potentially rotate through a birth center and observe birth in its physiologic form without all the technological bells and whistles and interventions, and that's a really valuable learning piece for people. There's the head of maternal fetal medicine at Beth Israel in Boston said he was raised by midwives and it made him a better practitioner. And so there's room for collaboration that way too. Let's see. So equity, the broadest conceptualization as equity as an issue in birth centers is just that place of where you give birth is a reproductive right. So just having access to birth centers, period, is an equity issue. And right now, Vermont doesn't have that, and we need to fix that. And then getting a little bit more specific, we look at populations. So for instance, many of you are, I'm sure, aware, because it's been a big topic that we need to address, but so Black maternal health, so Black birthing people are 3 to 4 times as likely to die in childbirth as their white counterparts, an unacceptable statistic. And in some cities, counties, it's up to 12 times as much. And I'm going to keep coming back to the same, it's no surprise, but midwifery care and birth centers are part of the solution to those statistics. There's a Lancet article recently that estimated that if we use a midwifery model of care and they named birth centers as being part of that, that we could prevent about 80% of maternal deaths. So that's huge. Other people, so was there a question?
No, just a cough, but thank you for.
Sorry.
I know Zoom kind of sounds are a little bit like you can't tell what the sound was.
Mm-hmm.
Also members of the LGBTQIA community who and other marginalized communities often feel safer going into a facility that is less institutionalized, where they have a personal connection with the providers, where they know who they're going to end up with in birth. It is very rare these days to have a baby in a hospital, even in Vermont, and know the physician or midwife or provider who is going to catch your baby. You may have never met them before, and that can be problematic for some people who want more of that high touch, low tech connection and to feel safe and respected and heard. And then new Americans are also another population. Many new Americans are coming from countries where midwives were, that was the standard of care, and they were either going to give birth at home or in a health clinic or a birth center, and they're used to midwifery care, and they come and they're like, what is this big institution, and so there's they're looking for midwives. I mentioned I worked in Central America and specifically in Guatemala, where everyone goes to a midwife, and so they're looking for that model of care. And then also, another category is just people with lower socioeconomic status, and I'm not going to say too much about this, but I mentioned I work at Copley, and we're, our birth center is potentially on the chopping block right now, and it's going to be a huge hardship for some of our people to get to Burlington or CVMC to get their care, which are the two hospitals that are sort of the closest catchment area. So, gas money, like getting a ride, do they have a car? How are they, relying on someone else? And so, just accessibility, and yeah, that's a huge consideration. And then just the model of care that is offered by a birth center, again, not a moneymaker. We spend more time, sometimes up to an hour every prenatal visit. And we also do postpartum visits in the home, and we do more of them. So we do maybe like a 48-hour visit, and then a week, 1 week visit, and 2 week visit, and a 4 week visit, and a 6 week visit. There's a lot, notoriously in the US, we do really poor postpartum care. We're like, oh yay, you had the baby, see you later, no one died, you're good, bye. Like, and really that's a huge transition. You've got a newborn, you're recovering from like the biggest event that your body's ever done in your life, and there's like a lot of room to do that better, and birth centers tend to excel in that regard. I think that's really what I wanted to say. And thank you for taking this up, and your time, and if there's any questions, I'm happy to answer them.
Anyone have any questions for Aaron?
I do.
Oh, okay, let's start with Topper. And then...
In your testimony, thanks for coming in, by the way.
You're welcome.
In your testimony, we talked about birthing centers reducing the death rate. I think this is what you said, by 80%.
Yeah.
Now, my question is this. We know that people who go to birthing centers are screened beforehand. They've had an easy pregnancy, if there is such a thing, and they're expected to have an easy birth. So how does that factor into that figure of 80%, reducing the death rate by 80%?
Yeah, that's a good question. And just to back up, so the statistic was about implementing the midwifery model of care. So and birth centers are a piece of that. So I just want to be clear about that. So the statistic isn't, having birth centers would lower it by 80%, but implementing the midwifery model of care, and birth centers are a piece of that. But yes, that is fair. I mean, for instance, we can say, at Copley, we pride ourselves on having a very, one of the lowest C-section rates in the state. So it's us and Gifford that are vying for the lowest. But is that a fair stat? We're sending most of our high-risk people out to UVM or other. So yes, does that capture a piece of, that we're already dealing with low-risk people? Sure, but this is also, this Lancet article was looking at comparing like European countries and Canadian countries where the midwifery model is already the standard of care, and then comparing that also to countries who don't have I think in the US midwives, there are about 15,000 midwives, and I think that we only do, it's a much smaller percentage of the births. I had it written down somewhere, but I'm not seeing it right now. So there is probably a little bit of a self-selecting population there as a factor, but it is, but even if it's 50% instead of 80, that is so worth it. And the reason why that helps is that you're getting, again, that high touch, low tech care where things, the famous story is like Serena Williams, right? Where she has a pulmonary embolism and she's saying like, hey, there's a problem, but she's in a big medical center and no one's really paying attention. Whereas when you have that one-on-one and you get to know your patients and you're screening for risk factors very heavily, because you can't hang on to the stuff that should be in a hospital, then you're giving very attentive care, and that makes a difference in birth. So emotion and trust and conversations and that whole relationship impacts birth probably more than most other specialties in hospitals, because not only because during birth, your sense of safety and your trust and your emotions affect the physiology so profoundly. I feel like I'm going down a rabbit hole, and I probably already answered your question. So, are there any other questions?
Thank you.
So you practice at Copley. Do you also in your practice, do you do home births?
I don't currently. I have in the past. When I hit my late 30s and 40s, I decided that I wanted a call schedule and to know which nights I might sleep and which nights I wouldn't as a home birth midwife. And I wanted to be able to do GYN care and contraception and annuals and all the other well woman care that most of the time CPM, certified professional midwives, aren't doing as much of. So yeah, I don't do home birth anymore. Hats off to people who do. Talk about a labor of love. It's a lifestyle.
Any other questions? Erin. Great. Well, thank you so much for joining us. Really appreciate it.
Yeah.
Taking time out of your day for us.
Thank you for what you do. It's important, very important.
Lauren, welcome to our committee this year.
Welcome back.
Yay.
You're in a new role.
The new role.
Hello, my name's Lauren Lehman. For the record, I'm General Counsel at the Department of Health. So thank you for having me here today. We are here in capacity as the per S18, we would be licensing birth centers. So there would be an application inspection process as well as licensing and license review and monitoring. We would also be responsible for rulemaking with the advocates and other people interested. I'm looking at it here on my phone, the requirements. I apologize, I didn't print it out before I came. So, we would help establish rules for the operation of the center, pharmaceuticals, obtaining, dispensing, administering, and maintenance at the center, changes of ownership, scopes of service provided there, appropriate staffing, complaint processes, equipment, facility and supply requirements, quality assurance and improvement, and process development would all be a rulemaking. All the boring administrative stuff is the Department of Health. So we would collaborate with the Department of Disabilities, Aging and Independent Living, which we do now for hospitals, ambulatory surgical centers, and other facilities. So it would be a similar model here where we would establish rules. Dale would go out and do inspections to ensure compliance with the rules and also for licensing requirements. We worked closely with supporters of the bill to help work through kind of what would be needed to develop a administrative licensing process for birth centers. So we're very comfortable with the language as written and can implement it. So it's short and sweet for me.
Leslie, did you have a question? Did you print out your stuff for us?
Yes, I have not, I don't have any written testimony, but just what I had here was the bill itself. I walked through the the rulemaking requirements. And so all of what I just read are the rulemaking requirements in the bill. I'm happy to submit.
Mari, and then Winnie.
I had a question yesterday about inspections and wanting to make sure that the people that were doing inspections of freestanding birth centers were qualified to do the inspections. They know the practice, they know standards of practice.
Yeah.
And I used a hyperbole, like we wouldn't want a plumber going in and.
Yeah. So Dale, they're probably experts on their inspection process, but they're all nurses that inspect the facilities. They're all trained in the requirements. Right now, they work under CMS regulations for inspecting hospitals and ambulatory surgery centers. Similarly, there would be a nurse who was familiar with the rules and the implementation, as well as the national accreditation standards, which are part of the rule process. And they would be the ones conducting the inspection.
The accreditation standards for that specific practice.
For the birth centers, yeah.
What is?
Yes. How often would Dale conduct inspections on these birthing centers?
Yes, so it's a good question. It is, they're authorized under the law to conduct inspections at any time. So I believe they do a preliminary inspection before licensure that would be required, and that is required by the bill as well. As a condition of licensure, you must have a inspection. And then if there's any complaints, you must have an inspection. And then thereafter, it would be at the discretion of the department.
So there's no scheduled inspection, say, once every 2 years, regarding this bill?
Not with this one. There are other, for the other facilities, they work under the Centers for Medicare and Medicaid Services regulations, and I believe those are every 5 years. One is required. This one is prior to this, I believe, requires, I need to confirm, and I'll check, but it might require an inspection prior to renewal. And that would be every 2 years, or every year. So I'm not sure if it actually requires an annual inspection. I don't believe so. I believe it's just initial licensure is conditioned on inspection.
I think, as I recall, there's been some issues with Dale doing inspections at nursing homes in the past. I think the Auditor General had a report out. I think it was last year or the year before. And I'm curious how they're doing on their inspections and things of that nature. Do they seem to have enough people to do those things? Are they doing them regularly like they're supposed to? And whether this is going to add to more work for them and getting behind with, the necessary inspections that they might have to do.
I can't speak on behalf of Dale. I am here for the Department of Health. It would increase the number of facilities they would need to inspect. Our understanding is there probably wouldn't be more than 1 to 2 additional facilities within the next 4 or 5 years. So it's a limited number, but I can't speak to their current workload.
I would like to know if you can get that information about the time period for inspection.
Absolutely. I can send that right after.
Thanks.
Is there hospitals, but is there a time period for nursing homes?
I'm not familiar with that. Yeah.
I was just wondering if you had someone from Dale. Talk about that? Yeah.
I got a question for somebody.
Yes, Alan.
It's a concern too, about the CON. We passed this a week ago, 2 weeks ago, and then we have a possibility of a project and we exempt them from the CON. I don't understand that, and I'd like to know why.
I think that we should be talking a lot about the CON. I think we're going to continue that conversation.
Okay.
Yeah, I mean, that's just a
Yeah,
piece.
I know this is
Yeah.
early stages, but like I say, to ask for the exemption kind of rings the bell for me.
Any other questions for Lauren? All right. Thank you.
Thank you.
Thank you.
Good to see you.
Again soon. Thank you.
Alex, come on up. Some of our questions could be asked, but answered by Alex.
I will do my best, Madam Chair. Hello, good to see you all again. Thank you, Madam Chair, members of the committee, for having me this afternoon to discuss S18. For the record, my name is Alex McCracken, Director of Communications and Legislative Affairs for the Department of Vermont Health Access, or DVHA. I will keep my remarks brief, as the committee has already heard a lot of valuable testimony from other witnesses over the last couple days, and I'll endeavor to not be redundant, Madam Chair. This is new territory for DVHA, as others have noticed. Vermont is one of only a few states that has not previously had freestanding birth facilities. As such, our department's work in this area is quite recent and limited. However, there is significant precedent and expertise nationally from which Vermont can draw. DVHA appreciates the evidence presented by the committee's witnesses that the creation of these facilities would likely result in lower overall costs for Vermont Medicaid. Medicaid already covers labor and delivery for home births and hospital births. In 2023, Vermont Medicaid covered nearly 2,000 deliveries, or about 37% of all the births in the state. Instituting birth centers in Vermont would not increase the number of deliveries, but would provide an additional, potentially lower cost facility for those deliveries. The intention of this bill fits squarely within the department's mission to provide high quality, affordable healthcare access to all Vermonters. DVHA also acknowledges the evidence presented that these centers improve health outcomes and may lead to increased health equity for Medicaid members. This, again, is directly aligned with our mission. I would like to provide 2 caveats and 1 language request on behalf of the department. First, that much of the implementation of this bill would fall to VDH, with DVHA acting only in the role of the payer. We would yield to VDH regarding policy and implementation and encourage the committee to continue to work with VDH on S18. Second, that Medicaid coverage of services in freestanding birth centers would require a state plan amendment to reimburse providers. Vermont does not currently have federal authority to reimburse for services in freestanding birth centers, so the agency would need to approach CMS, the Centers for Medicare and Medicaid Services, to obtain that authorization. DVHA recommends general caution when approaching CMS for additional authorizations, given the current federal context. DVHA would request that S18 be amended to remove the 7/1/25 deadline to submit a SPA request to CMS. That date does not afford DVHA and AHS enough time to conduct this work. Additionally, the department does not believe that language requiring AHS to submit a state plan amendment by a certain date would be helpful in the complicated timing process of approaching CMS for approval. The department would respectfully request that the effective date in Section 5D be changed to read, Medicaid coverage shall begin on 1/1/26 or upon both CMS approval and the effective date of the birth center rules adopted by the Department of Health, whichever is later. This will allow the agency adequate time to pursue the requested state plan amendment and align with the committee's intended effective date for Medicaid coverage. With those points in mind, DVHA is excited by the prospect of this bill, and the department would be happy to support S18 with the requested change to the effective language date in Section 5D. Thank you, representatives. Chair Black, I'm happy to provide any additional information I can on behalf of the department.
Any questions for Alex? Is there any modeling around potential savings to the Medicaid program? I mean, I realize obviously you can't predict how many there would be because we don't know what there aren't any that even exist anymore right here, but maybe modeling from around the country.
I think our best avenue for that would be to look at other states and what they've seen within their programs and what changes have been reflected in the cost to their Medicaid programs. I don't have anything specific for Vermont.
I know you all are really, really busy right now, but if we could just be starting to think about that.
Of course, happy to.
Also, Senator Gulick had referenced some information from AHS that she utilized. Is that something that you could provide us
The
with?
vital statistics?
Yeah, can you just send us,
I can,
our committee assistant,
I
that?
can track that down and send that to you.
Great.
Of course.
Any questions for Alex other than mine? Oh, yeah.
Are you aware of any states that require that birthing centers, freestanding birthing centers, use Medicaid instead of May?
That's a good question. I don't know which states mandate Medicaid coverage in birth center services, but I can look into that.
Thank you.
Yeah.
Great. Thank you.
Thank you so much.
Thank you, sir.
It's just me, or is it really warm in here? Yeah, we could close the shades. I see our storm windows are still on. So opening the window will not, anyway. All right. Oh, Jessa, sure. Put your head in the blinds. You might as well come on up.
Warmed up back.
Oof, I know, yeah, thank you for letting me get a little bit further from the heat. Good afternoon.
I'm sorry.
Oh, that's
I was.
happy to wait for you to be ready for me.
Thanks.
Jessa Barnard, I'm the executive director of the Vermont Medical Society. We represent physicians and physician assistants around the state. And on this bill, we've gotten a lot of input and connected with the Vermont section of the American College of Obstetricians and Gynecologists, OBGYNs. We both, VMS and ACOG, support all pregnant people in Vermont having choices about where they give birth and having the right to make medically informed decisions about their delivery and birth experience. We support accredited birth centers as safe places to birth and support patient choice. So our testimony today is really a focus on yes and. Yes, we support the bill. We support birth centers as an option in Vermont. And we need hospital labor and delivery services also to be sustainable so that when there is a higher risk delivery, there are safe places for all patients to give birth, for the lower risk in birth centers, should they so choose, and in labor and delivery hospital services when needed to be transferred. And we do think it's important for the legislature and state to be aware of the full context in which this legislation sits and the other challenges currently facing pregnant patients in Vermont and our state's labor and delivery services. As you are probably well aware and have in mind, labor and delivery services, much like emergency departments and intensive care units, need to be staffed and ready to handle emergencies at a moment's notice. Requires highly specialized staff, equipment, and services available 24/7 across the state. And our state's labor and delivery obstetric services are struggling, as I also am sure you know. The last witness didn't spend, or a couple witnesses ago didn't spend a lot of time talking about this, but the real challenge facing Copley right now, their CEO said in the press that they're losing $3 to $5 million a year on their services and maybe closing. As you know, Springfield Hospital closed their obstetrics unit in 2019. 19 out of 16 rural hospitals in New Hampshire have closed their labor and delivery units since 2000. Nationally, 217 hospital obstetric units have closed between 2011 and 2023, really exacerbating health disparities. And we are concerned that with Vermont already having the lowest fertility rate and birth rates in the nation, that we have a small population, we have a small number of births, and if we do further dilute the numbers of deliveries in any one location, that could close services. And we need to, as other witnesses have said, we need to work together. We need both. We need hospital services to be able to accept transfers due to complications, either during the prenatal period or during delivery. So what can we do about this? We have some suggestions that could, we think, strengthen the bill to help all labor and delivery services, regardless of where they take place, whether they're in a birth center or in a hospital. It's critical, we believe, to support well, let me just back up. Low reimbursement and losing money on the services is a large driver of why obstetric services are closed. And I think it was the chair, somebody asked a great question for when one of the national experts was testifying about, why do we pay so low for some services and more for others? Very complicated history, obviously, as you know, a lot of it driven, frankly, by federal Medicare policy that pays more for procedures than office visits. And on that list of low reimbursement are labor and delivery services. With over a third of deliveries in Vermont, as you just heard, covered by Medicaid, our recommendation is to include reimbursement for comprehensive prenatal labor, delivery, postpartum services under the enhanced primary care rate paid under Medicaid's RBRVS professional fee schedule. Our understanding is this would benefit both birth centers as well as hospital labor and delivery services, and hopefully help keep them all open and sustainable. So we did include in our testimony the list of those most common codes that we think are important to include. We also think there should be some more specificity regarding the written transfer agreements between a birth center and a hospital, and that they be with a hospital that offers comprehensive obstetric services within safe transfer distances. I have had some informal conversations with folks who have said, well, as long as there's an emergency department available. Emergency department physicians, amazing, great people. They do not want to be doing emergency C-sections in an emergency department. So this really, if there is an emergency transfer, we believe should really be at a hospital that has comprehensive obstetric services. Whether that's addressed directly in legislative language or through VDH rulemaking, we'd be comfortable with either approach, but do think it needs to be addressed. And there is, for example, much more specific language already in the statute around licensed midwives regarding a written plan for consultation and transfer Actually, not just for the woman in labor, but also if there's issues with the infant, to have nursery or neonatal intensive care services available. So we would suggest looking at that language and possibly incorporating some of that into S18. And you just raised this point. We do think it's worth the committee spending more time discussing whether removing birth centers from CON review is appropriate. We do think there is an important conversation to be had about how many birth centers, where, how they impact hospital birth facilities remaining open. And those are some of the types of questions that are directly addressed through the CON process. Or if there was another process, not quite CON, but some kind of a review of the location and how that impacts the whole state, just like there is a review going on right now about hospital services where they are operated. We think it needs to take place in the context of sort of a whole state plan for how we make sure patients have access to safe and appropriate care in various settings. So thank you. Thanks for considering our feedback. Happy to answer questions.
Any questions for Jessa? This is just for my own help. Where's the CON language in here?
In my testimony or in the bill?
In the bill.
I do not have the text in front of me.
It's there somewhere.
In the Senate bill, right?
Yes. And Kirby legislative council, bottom of page 8, it's section 3, it just amends 18 VSA 9435A and says excluded from the subchapter. And that subchapter also subchapter on certificate. We have it.
Thank you very much.
I got another question for somebody. If Copley's losing $3 to $4 million a year and others are saying they're losing, why do we need one? How's that one going to make a go of it?
I think the question of how many deliveries we have in the state, where they're currently going, where they could go, I think there is certainly I believe an open question. I know you've heard witnesses say this will actually bring births back to Vermont that are happening elsewhere, but it's unclear to me. I don't think we actually know the data of why those births are going out of state. They could be going to Dartmouth because they need or Massachusetts because they need high risk care. And those would not be folks who would come back into the state for low risk birth center. It could be that they are, because there is a birth center in New Hampshire. Maybe they're going there. I don't know that we have that granular data to really know. Maybe we would be bringing more births back, so it's not competition. We have plenty of births to go around, or maybe that's not the case.
But that's the reason I do, and I'm inflexible, but I think the CON is necessary because the need. Do we need 4, 3, 2? Who's going to answer that question?
When I'm not going to answer the question. I will. I guess I'm going to pose a question to you. Wouldn't the number of women that choose to give birth in a freestanding birthing center, wouldn't they be the ones that are making the determination of how many are needed?
We don't know those numbers.
We don't. But if someone opened one and they didn't do any births there, I'm pretty sure it would close because of a lack of.
They would ask us for money. They would ask the state for money.
But it's.
They would have to be state-owned.
They would have to be state-owned.
Well,
Or state contracted.
we give money to different organizations.
If I could say, make one more point about the CON process, you just spend a lot of time looking at thresholds. And I think the question is, should those thresholds apply to all entities? It may be that it is a very teeny entity that would be under the thresholds you're setting for everybody else. It could be that it's, who knows? You're just talking about private equity. I'm making, totally speculating. What if there were some big corporate entity looking to open a birth center that was over those thresholds? Should those thresholds not apply? There's a reason you've picked monetary thresholds at more than in or out completely. So I think it's a question of, do you apply that across the board, or are you exempting? What would be the philosophy behind exempting a specific end?
I guess that's my question.
Mari.
So at CONs, as you said, we've just taken a lot of testimony and passed the CON bill out of the House, and hearing how burdensome the process was for large institutions that have a lot of staff who can work on the CON application. And how burdensome it was for the Green Mountain Care Board, and everyone was unified around that issue. So if we're looking, if you're looking for some way to evaluate freestanding birth centers in the context of our state plan, aren't there other ways we can do that than potentially requiring, depending on the thresholds, which I doubt they would hit those thresholds. But aren't there other ways that we can, as a state, evaluate the place of freestanding birth centers in Vermont, other than going through?
Yeah, I think they're
process
right.
we said, we've
It's
already
burdensome.
said.
Yeah, and I wouldn't argue for applying different threshold, like lower thresholds to birth centers, for example. So I do agree that it should be consistent. If they were to be part of it, it should be consistent with other facilities. That said, yes, I think there are also other ways to look at it. In the past, we've thought about, well, what about the health allocation resource plan? Thank you. Yes, HRAP. Like, would that be more of an appropriate, like, let's look at, you'll be seeing the bill coming over from the Senate Health and Welfare Committee around kind of a plan for the state in terms of health resources and where they are. It's sort of a new plan that you'll be looking at. I think there could be ways outside of CON also that it would be perhaps less burdensome, but at least some state entity or body weighing in on how might this impact our system as a whole and patients as a whole.
In some way for the public and for the providers to have a real voice in how they fit into this.
Exactly. And I think that's really what we're asking for. There could be population centers in Vermont that could more than adequately support both a hospital and a birth center, and then parts of the state that really couldn't. And if we lose a hospital there, then again, the higher risk pregnancies would have nowhere to go and really have a large distance to travel. So I think the location potentially does matter a lot. And right now the bill is basically saying, leave it up to the free market and see what happens. But there could be more of a planning process to help inform that.
I guess I disagree with the notion that freestanding birth centers would be the key factor in hospital birthing centers closing. Just with the numbers that we know nationally of people who give birth in these centers, I just don't see that.
I think we are talking small numbers. I think the question is how big. I think I don't know that. Some of the hospitals are so close to numbers to support their units currently that it could be small numbers could have big impacts. If they're already on that verge of deciding, can we continue to support this unit? I agree. I don't think we're talking about big numbers, but.
Did you look also at the numbers of home births in areas of the hospitals that are concerning, and how much home births have impacted the bottom line? And I say this also with not frustration, not at you, just in general with our system that's built on financial incentives, not on the focus should be on the person who needs the care and having a choice about where they get care. And we're constantly having to, all of us here who've been at this table many times, focus on the financial part of it, which is real. I get that. But anyway.
I agree. That is the tension. I think the issue is, we agree with that choice piece. It's just, we also need a place for higher risk deliveries, and we will, and they need to be available 24/7. And that is an expensive service and a money losing service. So there are both realities. Yeah, I agree with you.
Regarding the piece around a written transfer agreement. And maybe this would be actually a question more for Aaron or OPR, if we ever had OPR, or what I really don't know. I don't know the answer to this question. Do certified nurse midwives or do midwives have to have, as far as their licensing, do they have to have some sort of collaborating relationship with perhaps an obstetrician, or is there? Yeah, go ahead.
Excuse me,
Just
Laura Foster, from the Vermont affiliate of the American College of Nurse Midwives and the Vermont Birth Center Coalition. I can either address these questions during my testimony or I can answer this question just now. What would you prefer?
Let's address it during your testimony then.
Okay.
That would be great.
I can clarify, the language that's here is for licensed midwives rather than not necessarily nurse midwives. So this transfer agreement is for those practitioners. Or the written plan. And again, the language might not be entirely one for one, but the concept of having a written transfer plan, ideally that the hospital is aware of in advance.
Mark. This was years ago when I was considering home birth and disclosure, my daughter is a licensed professional midwife. And I seem to remember 10, 15 years ago, there being significant tension between licensed professional midwives and receiving physicians or providers at hospitals. So if there is a requirement for this agreement, who's to say there's going to be a willing provider at the hospital, or that the hospitals would be willing to, unless they're told they have to, if they're required to have this agreement.
I have not heard, there was certainly tension in the early days. I have heard things are going pretty smoothly now. I can say that having talked to some of our OB members, the biggest, the situation they like to be in the least is sort of a surprise transfer that they've never met this provider before, they've never heard of the patient before, sort of this, they come on, at the last minute in a major emergency. I think when they know the providers, they have the plan, transfer plan that they've talked about ahead of time, things seem to go fairly smoothly and they have a good working relationship. I hear your question. I mean, maybe there'd be a way to make sure that they can find an entity willing to enter into this plan with them. But I think having it be a one-sided, they come up with a plan, but nobody's aware of the plan, doesn't necessarily actually help for the communication and smooth transfer when that arises.
Thank you, Jessa.
Thank you. Thanks for your time. Appreciate it.
Hey, Devin.
Hi. Devin Green, Vermont Association of Hospitals and Health Systems. Thanks for having me here today. And I will just start off by saying we do support birth centers. We support patient choice, and we really appreciate the work that birth centers do and the care that they provide. I'm going to key off a little bit off of what Representative Cordes said about having to think about the money and that being unfortunate. I agree that we would not like to think about the money in this scenario. I was hoping with hospital global budgets that would be a more sustainable way to do things like births in the hospitals and having birthing units. My point is just to say that the birthing landscape in Vermont is tricky just because we do have the lowest birth rate in the nation. I think all but our largest hospital basically has basically like one birth a day. So very low birth rates at our hospitals, and a small amount of numbers will impact them. So for instance, we were talking about Brattleboro Memorial Hospital. They have said if their births were reduced by 2 births a month, that they would not be able to sustain their birthing unit. What we're really asking for is not to have birth centers competing with hospitals or trying to look at this limited pot of money, but to more sustainably fund birthing services. And so in that, we would ask you to look at increasing the Medicaid reimbursement to help sustainably fund those services. So that's my first big ask. My second big ask is, I was alarmed yesterday by the testimony where we were talking about transfer plans, and it was said that, well, hospitals have EMTALA, and so we don't need a transfer agreement. I'm not saying that we require a transfer agreement with the hospital. I just don't like the idea of, right now, the language is very vague. It just says a requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital if circumstances warrant. That could be, and no one here is ever going to do this, but we're just worried about bad actors. That could be someone putting someone in a van and shipping them off to the emergency department. If you look at the ambulatory surgical center statute, and if you look at the midwife home birth statute, they just have a little more detail around those plans. So as opposed to just saying, just get them to the hospital somehow, do we have an agreement with EMS, or do we talk about, care for neonatal, like having opportunities for neonatal care at the receiving hospital? I'm not saying that an agreement with the hospital needs to be in place. I'm just saying there should be more detail to avoid emergency department birth. That's not something that we want to see.
But can I just ask for clarification? In the bill, maybe Jen could wait, is that in the rulemaking process?
That's in the rulemaking process.
Okay, so wouldn't the fact that we have that in there during the rulemaking process, wouldn't they probably come up with language? And so there's already for home births, so
that's in statute.
Okay.
So that's in statute, yeah. And so the language here is just a requirement in the rules that there be written practice guidelines. So the rules could just say have written practice guidelines that include procedures for transferring a patient to a hospital. It wouldn't need to get any more detailed than that.
Okay, let's think on that. Daisy.
Sounds like you're suggesting that we really make it clear that birth centers should have transfer plans and that they're transparent about that with a coordinated hospital. There be some sort of MOU in place or something.
Not necessarily. I was working with the coalition's lobbyists. I think I understand the coalition's concern. What if the hospital doesn't want to work with us? I agree with Jessa Barnard that I think relationships have been smoothed out. But if that is a concern with the coalition, I think there are just a little more, again, initially when I saw this, I thought, okay, great, a plan for transferring to a hospital. But when I heard about the plan may only be that we bring them to the emergency department, that raised a big red flag to me. And I just like a little more detail there.
And then it kind of follows that if they have to have some sort of plan for emergencies in place with the hospitals, that the hospital would then have to have a birthing facility on site.
I am not even saying that the requirement is that there is a plan with the hospital. I think that would be optimal. I do hear the coalition's concerns around that. But an ambulatory surgical center, for instance, just needs to have an agreement with EMS for transport. They don't need to have a transfer plan with a hospital. I'm just looking for something a little more, some more parameters that are acceptable to all parties in this instance.
That's helpful. And then I think, to the money piece, I think it's actually good that we're talking about that, about the financial piece, and it might be uncomfortable because birth and life is such a personal and emotional thing for hopefully all of us. But I do think that's a key factor to this, because everybody in this room is trying to make healthcare more affordable and more accessible right now. But I mean, the fact is a hospital birth is around $30,000, and a birth center birth, I mean, mine and most of the people I know was around $3,000. And so I think we can't ignore that as much as we don't want to think about the fiscal part. And so I think in my head, just so we're all aware, because if I'm not the only one thinking it, is the fact that if a hospital can't stand to lose 2 births a month,
It's pretty bad.
what are we doing? You know, we're hanging on by a string, and I think we can't sacrifice Black maternal health.
I'm not asking you.
I know, but I'm saying I represent a community with a lot of diversity, including Black women, and I support birth centers, and I just think, you know, my heart goes out to the hospitals who can't stand to lose 2 births a month, but it's really hard to balance these 2 needs.
I also support birth centers. But the other financial dynamic is that when a birth center comes into the area, they take low risk people, which means that a hospital will likely get more, they will have a higher percentage of higher risk people. In addition, if we're talking about equity, we want both hospitals have to accept Medicaid. We want birthing centers to accept as many Medicaid patients who want to go there as well. And so we should make Medicaid more sustainable for both places.
I'm gonna let the high risk people rest, because I don't think that birth centers really take that many births away from hospitals, according to the testimony that we've heard before and hear about that.
I understand.
They're not competitive, and I don't think there's any evidence. I mean, correct me if I'm wrong, if you can share with us evidence that any birth center has put a hospital birthing facility out of business. I am very eager to see that data.
Again, Representative Rebecca, I am supportive of this bill. I've asked for a few changes.
I'm not suggesting otherwise.
Yes.
I'm very curious if there is, and I think it would be very important for the committee to know if there is a circumstance of birth centers taking births away from a hospital facility. I think that would be critical for us to know. So if you have data on that, please share it with us.
Okay.
And the question I keep asking, which is, I do believe there is a competitive, but I don't think it's hospitals and birth centers. I think it's birth centers and homes.
Mhm.
And that frightens me,
Mhm.
because I believe that there are probably women who should not be having births in homes, and yet are because they won't go to a hospital.
Yeah.
Is there any data on
I'm
that?
sorry. Apparently, I keep asking for data, and I don't think that the data exists, but, so I'm just surmising here, but,
Oh, no, my other part, okay.
yeah, no, so go ahead.
How many deaths?
Sorry.
How many deaths, how many births in Vermont a year? Any data?
I have that on my sheet that I just closed down.
Approximately.
It is listed on your website. Let me see if I can get it
I'll
up.
find it when you get,
5,868.
how many?
5,868. And that's
5,800.
home births and births at hospitals.
That's total births.
Do we know how many home births there are?
This says 176. Yeah, I mean, they have to,
Yeah,
They have
they
on the
have
birth
a birth
certificate.
certificate.
yeah.
So that's a lot.
But a lot of those are elective, they want to.
Well,
You want to be at home, but they may choose the birth center should they
If
have
it's
an
They
option.
available.
may or they may not.
But they may.
They may not.
There's a gap. That's what we're trying to fill.
Mari, did you,
It's more of
I'm
a-
sorry.
Fine,
were you
no,
done?
that's good, yes.
Okay.
First of all, I think, I do want to hear about the transport plan. It's good to know, maybe there's some language with all of the stakeholders that we can
Agreed.
come up with. I do think we do need to pay attention to the problem where of the fertility police in the past where there weren't any receiving providers willing. And then just, I hear you say that VAS supports freestanding birth centers. And I know we just keep talking around this issue, but I have a fundamental objection to inequities are in the system are already foisted upon people with minimal financial means, Black pregnant people, and those communities. And here we are placing the burden of whether a hospital stays alive or not on them. And it's just fundamentally not right.
I, again, support this bill. I just want to give you, this is the reason I'm talking about the landscape and the low birth rate and where the financial status of our hospitals right now is just to say, let's think about ways to make birthing services sustainable for all so that we don't run into that problem.
Thank you. And I will just say thank you both to you and to Jessa. You know, the old saying of, you know, don't tell me what you care about, show me your budget. Mine has always been, don't tell me what you care about, show me your fee schedule. And it is a great reminder that these codes that you both have listed in your testimony, the reimbursement rates on these are abysmal. So thank you for reminding us of that. And it is not a coincidence of what those codes are. And if we say we value something, they shouldn't be abysmal. So thank you for the reminder. We need to do some math. Okay, thank you. Rebecca?
Hello. For the record, my name is Rebecca Gray. I'm really excited to be here. I'm going to be talking from a consumer advocacy perspective. And maybe it's going to be a nice break from the past few, but I'm also really excited now after hearing everyone else talk to bring it back to the patient perspective. And I'm really excited to see what questions come out of this one. So from my advocacy work, I am a full spectrum doula. I've been doing that for a number of years. I came into wanting to do that type of birth work from going through my own experience with my first pregnancy. And it's been really interesting. We end up having a lot of conversations with our clients around options for birth. We support people going to the hospital to have their babies. We also support home births. And we talk a lot about that third elusive option. A lot of questions that we end up getting from our clients is about like, well, why doesn't Vermont have this option? And we end up having a lot of conversations with those clients going into their delivery experiences about self-advocacy, especially when it comes to having hospital births. I then came into contact with Mari, actually, who sent me over to Laurie Foster. When I really wanted to actually dive deeper into what is going on in terms of opening freelance birth centers in Vermont. So that's kind of how I got here in front of y'all today. For my consumer side of things, I've had two babies. They both were born in Vermont. My son was born December 2021, and my daughter was a home birth, and she was born May of 2023. So I can confidently speak from both sides of the spectrum. I've done a hospital birth at UVMMC, and I've done a home birth in a rented house in Essex Junction. We actually got pregnant with our first when we were in North Carolina, which is a very different place than Vermont. I don't know if you've heard. And this was during COVID as well. So we started out with a provider, a very popular provider in the Asheville area, and then quickly realized that that was absolutely not the situation we wanted to be in. was a hospital-based provider. The hospital in Asheville is Mission Hospital, extremely well-respected hospital, very high volume. And we had a number of traumatizing experiences with this first provider. So we actually ended up switching providers. This is when I did research again, and I found the freestanding birth center in Asheville. And the second that we walked in the door, I was like, this is it. Like, this is the level of care. I learned immediately upon my first appointment, I learned what the midwifery model of care was for the first time. I learned what a CNM was, what a CPM was. I learned about what transfer means to the hospital. And I learned a lot about what pregnancy was that no one else was able to provide us this level of information until we got to this birth center. It was unbelievable. And it also offered us the opportunity to be excited about being pregnant for the first time. 2 months later, they closed. COVID hit them really hard. They were a nonprofit, and they couldn't sustain themselves. So we transferred again to MAHEC, which is an education-based provider that also works out of Mission Hospital. And we felt like we were right back to square one with what we were looking for support. They also were a high-risk facility, so they got the highest risk patients all came to MAHEC. And so because of that, even for someone like me that was low risk pregnancy, we were treated as high risk. So for example, in Vermont, we do screenings for, we do the glucose test screening. For every patient, no matter where you were on the scale, you did the 3-hour screen. So for those of us who've done that, but that was what they did for all of their patients.
Now you have sugar. I did it, it was orange and it was disgusting.
They really talk up the orange, so you might have made the right choice. We really struggled for a few months after we got pushed back into the type of provider situation, knowing we were going to have a hospital birth in North Carolina. We actually ultimately decided to move back to Vermont. We both had come to Vermont and moved out to kind of get out of the state. And we made the decision to move back. And I think that a huge part of that decision was centered around this idea that we had of Vermont, that we wanted to go home to. It was familiar. We loved what Vermont stood for. And especially during COVID times, it felt really safe to come back here. And I really thought that we would get here and we would find the birth center that we were going to have our son in. Hospitals do a really good job advertising their labor and delivery units as birth centers. So I think naivety took over and we came home. And we transferred to an independent provider here, and I had a hospital birth. And I had a very standard, no intervention, no medication birth. And I advocated for that the entire time. And I left the hospital and I was like, I don't think we really needed to be here. And I still was like, where is that third option? That would have been perfect. And we had a taste of it, right? We had a couple months where we got that midwifery care, and it was guaranteed we would have a midwife at our birth. And that was gone. Jumping to my second pregnancy, we did a home birth. I didn't want a home birth, but I also absolutely knew I was not giving birth in a hospital again. The home birth went fine. She was born at home. It was a really fast labor. But we were in a rented house, and I ended up buying my neighbor a 4-pack after because he listened to me give birth, and it's not quiet. So there was a lot of things. We had a toddler. We had a lot of dogs. We didn't own the house, but there was absolutely no way I wasn't going to do it there. I talk a lot with my clients, a lot about your options and reproductive rights and self-advocacy and all that stuff. And it's very interesting that we still don't have that third in-between option. I would say from my perspective and from my experience with the amount of people that I've come in contact with going through their pregnancies, that most of them would have chosen a birth center over anything else. I know it doesn't hold statistical data or water, but I do know that it means a whole lot when we as birth workers are talking to people about options. And I think it definitely would make a huge difference for the amount of people that we see that want that type of care, including myself. I'm done having babies. That ship has sailed. But I will never get that experience that I really, really wanted out of my births. And I mourn that for sure. But I absolutely will not help having this become an experience for people in the future, and hopefully really soon, because I think that that is like, in my mind, that's like what Vermont is. Vermont stands for reproductive rights. They stand like next to their patients and they care, but like that hasn't been shown yet without this bill. Thanks for your time.
Thank you.
Thank you.
What do you have?
I just have a couple of comments.
Please.
It's probably sexist. I'm old fashioned, okay, and I can't. Well, my wife and I are no longer having babies, but I can't imagine having a home birth or a freestanding birth. And I respect your choice and others that want that. My question is, why can't we, with hospitals, provide customers, mothers, what they want at a low price, with the room the way they would like to see it, and have that experience that you had for 2 months? Why can't hospitals do that? I don't know as if there's an answer to them.
That's where I was. Like all I do.
But I'm sure there's other issues, medically speaking, that people are looking for, a particular experience. Anyways, that's just a comment. For what it's worth.
Devin.
Devin Green from Buzz. I would say that I agree it should be the norm. I think some of our hospitals do a good job of it, and have really amazing birthing units that do offer a home-like setting. A lot of the things that would be in a freestanding birthing center. That's not to say that we shouldn't also have the freestanding birth centers.
Well, I'm not saying we shouldn't have as well, but I'm just saying, why can't hospitals provide what the customer would desire in this birth?
I think some hospitals do. And I think that having that option, whether it's a small local hospital like Gifford, they have a beautiful birthing center and they really kick ass there. And so does Copley. And so does Porter. There's so many. But you're still in a hospital setting, and there's really nothing that a hospital should do to make it seem otherwise. There's a time and place for having birth in a hospital. And there definitely is a time and place for having birth outside of a hospital. And I think the main argument here is having those options. There's no reason to not have a third option. Is the number 3 like offensive to us? No, like there should be a third option. And I think that that's coming from a consumer perspective. And there's a lot that obviously goes into creating options. But I know that on the consumer side, there is that want for this. And there is this idea that Vermont, for everything else we stand for as Vermont, it fits in really well with that.
Can I say something?
Yes, of course.
I think the other thing about it is that once you walk into a hospital, you have a receptionist at the door, and the price goes up immediately upon walking in the door. That's the big, it looked like you want it to, but it's not gonna cost what you want it to.
Well, like I said, why can't we also include the lower price as well?
Yeah.
With what we.
We're working on it.
Maybe we should also remember that for the whole of human history, births were not in hospitals.
That's right.
Well.
There have lots of women died. And have we medicalized birth? Is giving birth a medical? Is it a medical problem? For some,
people.
for some,
Yeah.
for
Some
some people.
When you have high blood pressure and diabetes and
Yeah.
anemic, you need to be in the hospital.
Well, thank goodness we have hospitals then.
That's right.
But for someone like me who had none of that and constantly was made to feel like a ticking time bomb, when am I gonna get sick?
Yeah.
Oh, I never did, but I'm still treated that way. That's not fair.
Any questions for our witness? I'm sorry, we've gone off on a. I've forgotten that you're here joining us. Just really quickly, because, we also have S53. So you're a practicing doula?
Mhm.
And I'm just curious from, like, of your clients, I guess you would, well, I'm not sure what your.
Clients, absolutely.
Okay, clients, what moniker you use.
Clients.
Um,
We're non-medical providers, so not patients.
yeah, no, we've done a lot around doulas.
Yeah, I've been following.
Talked about,
It's exciting.
I'm just curious how many people you see? And do you have discussions with them? I know that you sort of alluded to the fact that there isn't this option that you can offer people, but I'm just curious on the
Yeah, like what we've been.
of the women that I'm sorry, the people that you see.
Yeah, so I'm trying to think of like a good number. We go by is how we schedule ourselves. There's 4 of us right now working for VDC that are on like the birthing team. And we're seeing around 10 births a month. That obviously doesn't necessarily mean when we're scheduling estimated due dates in a month. Not everyone falls nicely in that square. So we're seeing for what doulas in Vermont are seeing in terms of client flow, we are seeing a lot for our like agency. The conversations that we're having around these, when people are choosing where to have their providers and where they want to give birth, a lot of the conversations do tend to be around the different types of providers. So, for example, Copley, we love supporting people who go to Copley because we know that the midwifery model of care at Copley is extremely strong. And we know that a lot of our clients are looking for that type of care. We also are at UVMMC very often, and a lot of the clients that end up there should be at UVMMC. We have a lot of people who they like the idea of doing a home birth, but for all the reasons that come with why people end up not doing a home birth, nothing to do with medical situations, they choose a hospital over a home birth. I would say during our like initial meetings with people, probably about 85% of them bring this up to us. We're still choosing between this or this. We really like this part, but I don't think I can get my partner on board with home birth. That's a big reason. And so we're having a lot of those conversations around things like that. And they're like, well, what else is there? I've heard of, New Hampshire has freestanding birth centers. Is that something that you guys would be able to drive to New Hampshire to meet us? Is it worth it? Stuff like that. And then they start brainstorming loopholes around that. And we're like, it's not feasible on so many levels of not just non-medical supportive care to a client, but also as a patient to drive out of state to have your baby. So it's a lot of those types of conversations. I might have gone down a rabbit hole, but
That's all right. Okay, Thank you.
Yeah.
Thanks so much for coming here. Lori. And I bet Lori has all sorts of other questions she's gonna answer it. So I think she's been taking notes.
I've been taking notes, and don't worry, this is not a novella that I'm going to read to you. So I'm Lori Foster. Thank you so much for taking my testimony. I'm a certified nurse midwife. I have been serving Vermont families since you're looking worried.
No.
Oh, okay.
Worried.
Did I do something? Since 1982, and I have worked in all settings. I trained actually in birth centers in Texas, and then I had a home birth practice for 25 years in Vermont, and also worked at Gifford. And I've worked in a small community hospital with a 3 midwife practice, and for a couple years in tertiary care center. So I have, kind of seen it all. I'm currently the legislative liaison for the Vermont affiliate of the American College of Nurse Midwives and a member of the Vermont Birth Center Coalition. And in my testimony, I do want to avoid repeating things that you've heard because, there always is repetition. So what I want to try to do is just highlight the things that both of those organizations feel are so important about this bill, and then address some of the concerns and questions that have come up. Does that sound like a good plan to people? Okay. So the highlights, of course, are that Vermonters believe and support reproductive rights and health equity, and we know that this bill will serve that. We know that birth centers do offer better outcomes, and I did want to take a moment just to condense the reasons for that. You've heard probably all of them in pieces, but it is the intensive, personalized health promoting prenatal care that people receive in birth centers. It's the continuity of care, so having someone that you know and trust throughout your pregnancy, throughout your labor and birth, and in your postpartum. It is the one-on-one labor care, and that does help avoid, a lot of problems if there's someone there watching the mom, watching the babe the whole time. And that can't occur in some settings, like big hospitals. I have worked in one. There was no way I could sit with my laboring mom like I did when I did home births or even worked at Gifford. You have to run around and, take care of multiple patients all the time. So you can't really deliver that midwifery model of care in that setting. It's the avoidance of unnecessary interventions that Dr. Fisher talked about pretty eloquently yesterday, I think, explaining that those procedures, those guidelines, and actually Rebecca referred to that, are there and they're used, for everybody when they're not needed for everybody and can actually create problems for people. And there's also the really excellent risk assessment that's done, and that's done prenatally. And it is also done during the labor process, so if you see prenatal problems coming up, then that person will be transferred to a hospital care environment. If you see problems during the labor, that will also happen. And we know that the intrapartum rate of transfer in birth centers is around 10%. Okay. So that's what creates this, this difference in outcomes for people. And I think, we've heard about the lower C-section rates. That's beneficial from the standpoint of your postpartum recovery. It's beneficial from avoiding the risks of major surgery. It's beneficial from the standpoint of not being, what we call, having had a cesarean with your next pregnancy, where you could have some problems that are related to that. And it's also, of course, a pretty big cost saver, because cesareans cost a lot more money than vaginal deliveries. And then the preterm baby and low birth weight baby, the reduction of that, I think, is really something that's so significant, because it's very stressful, obviously, for the baby to be in an intensive care unit. It's very stressful for the parents to be trying to care for that baby and be present for that baby. It takes a lot of resources, and it is incredibly costly. And there are certainly times when that has long-term implications for the child as the child develops. So that's in my mind kind of really big. So those are things that I think highlight why this is a great idea for Vermont. So I want to go ahead and try to address the concerns. And I please tell me if I've missed any. So, we've talked about the CON. There was a question about why are we putting a CON exemption into this bill? When the bill was written, the H96 we knew that things were coming, that people were going to work on the CON, but it wasn't developed, and I think that what we know about, and I want to thank you guys for doing all that work on it, because it is such an important issue, and not particularly for birth, but just for healthcare in Vermont. And the new thresholds are thresholds that the likelihood of a birth center ever reaching them is, probably 0.001. An $11 million birth center is very, very unlikely to happen. The concern at this point, taking it out of this bill, is that there is the transfer of ownership in the H96, as I understand it. And that really would make a birth center non-saleable. Because again, you've heard many times, birth centers are labor of love. They're not usually run by people with lots of resources, money and extra money that they can afford lawyers and staff people to be working on, large bureaucratic things like a CON. So if a midwife opens a birth center and she, for whatever reason, has to move out of state, or say she becomes ill and can't continue to practice, and she wants to sell her birth center, and her community wants to still have the birth center, if she has to go through, if the next person has to go through a CON in order to keep that birth center open, it's probably not likely to happen. We do know from national data that CON is a very significant barrier to opening a birth center anywhere in the country. And the AABC has a lot of data on that. The majority of states don't require it. Those that do, a lot of them are changing it. 8 in the last several years, 8 states have revoked the CON for birth centers. So I think that, keeping it in the bill as it is, as Shayla Livingston said yesterday, it just keeps it kind of cleaner and more straightforward. We know that a birth center won't have to go through a CON. By passing, if we pass this legislation, we're saying Vermont needs birth centers. So it's not like, is this necessary? I understand, the testimony that has suggested that we need to control where they're opened. I just think, we have to really ask ourselves, like, what does that mean? Does that mean that people in Chittenden County should have a choice, but people in Windham County should not have that choice? I think it's tricky. I get the concern around the money, but I agree with Representative Rebecca that you can't, if 2 births a month is going to close a birth center, then there should be another way around that. And I wholeheartedly agree with trying to get better Medicaid reimbursement, and Devin knows that, and it is a very political thing, as you probably know, that, services for women and children are not well reimbursed. So that's something that as a coalition, if we get this bill passed, we will throw our energy right in there on that one. Yes, because I think that really is the solution to the failing birth centers. And but we really don't have any actual evidence that the presence of a birth center would close a hospital unit. So I think that's the other thing we just have to keep coming back to. And the idea that we could do some kind of a process that would determine that, I just don't know how you're going to get that kind of information or data. Do you know what I mean? Like, how can we really determine in any one place, would the birth center, number one, take away those births? Would that, number two, close the hospital? I just think that's going to be a really hard thing to drill into, and not fair to, the population of Vermont. If we're saying Vermonters should have birth centers, then, that should be open to whoever can manage to get one started. So that's kind of my feelings about the CON. Should we talk about questions topic by topic, or do you want me to keep drilling for these questions?
Anybody have any questions regarding that, the CON? Topper.
Thanks for coming in. You mentioned controlling where birth centers are. When you talked about it, I got the feeling that that shouldn't be done.
I don't think it should be done, because I know, I mean, I understand the money part and the concerns.
Mine's not money.
What's that?
Mine's not money,
Uh-huh,
my concern.
uh-huh.
And I don't know if it's called control where they are, but I think those, if we do this, that it's imperative, that this is my opinion, that the location of the birthing center is in close enough proximity to a facility that can handle the emergency that might arise as a person is given birth. That's, I don't know if that's called controlling where they are, but I think it's, again, imperative.
Right. I think it's a really good point. From my thinking, another topic, when I was talking about controlling, I was referring to the idea that even if we don't require a CON, we have some other process to determine if it's okay to open a birth center here or there with the regards to, is it going to impact the hospital in that community versus what you're talking about, which is like, in my mind, more the transfer issue, which I totally will address. Okay, does that make sense? Yeah, okay. Anything else on the CON?
I'm going to ask a really dumb question.
As we say, no questions are dumb.
So as I've been thinking about this bill, I do a lot of Googling.
Ooh.
And I ran across, because I was thinking about private equity, because we're also doing some stuff with private equity. I'm like, hey, is private equity getting into birthing center? But I ran across advanced birthing centers, not here, but essentially large birthing center, for-profit birthing centers. And they're called advanced birthing centers. And I'm thinking about the CON process. I don't think we want $10 million freestanding birthing centers. I don't think you would want that. I certainly know our hospitals would not want that. Is there a way we can address the concerns around the transfer? The ability of a nurse midwife who has a birthing center and would like to retire at some point in her life and transfer that to someone else. Is there some way we can address that concern without explicitly exempting birthing centers from the whole entire CON process? So that still those monetary thresholds would hold.
I mean, I guess that's honestly more a question for y'all, because can it be written into the statute rather than a CON exemption? An exemption to the ownership transfer. I mean, I guess the H-96 is not completed yet, right? So we don't know exactly what the language is going to be. I guess the other way of doing that would be to put, that the birth centers are exempt from the CON process unless they reach the monetary thresholds.
I guess what I'm asking is your only concern with our current CON process, is it really just about that transfer?
It's about creating a barrier.
Okay.
Because we do know that to do a CON process, a lot of time, a lot of money, all of that will make it so birth centers won't open. And this whole entire thing we're doing is therefore kind of a futile exercise in whatever, Yeah.
Leslie, did you have a? So I'm wondering, and maybe Jen, you can help me with this. Is there a similar parallel if an independent practice sells their practice to another person, another entity? Would there be a parallel in
Jen Garvey, Legislative Council, no, because offices of independent providers are already exempted, whereas this is, you're talking about effectively a facility that would, unless, unless otherwise, carved out, would be subject to CON. So I think there's already an exclusion that where we added in the S18, where we added that exclusion from CON is adding it from the whole subject, or is adding it to offices of physicians.
Okay, so that would be a parallel that then we would parallel it with that. If we kept the exemption, it would be parallel with independent practices, selling independent practices would be the
Well,
same
the-
level.
Yes, but it would be anything. So right now, independent physician practices are exempt from CON regardless of the monetary thresholds. So, and I think what you're starting to talk about is maybe not having an exemption from the entire subchapter, but maybe having an exemption for birth centers from CON for transfer of ownership.
So another exclusion?
Yeah.
Yes, but more.
Not the exemption,
but
yeah,
more-
complete exemption, but.
Right, more targeted. I think you would put it in, right now there's, it also says a nursing home is exempt from the CON requirement for transfer of ownership because it's handled separately. And so I think you could add, if you were specifically concerned about that, you could add it there, or you could add it with some caveats if it fell below a certain, the value or the operating budget, or something like that was under a particular threshold, then it wouldn't be subject to CON for transfer of ownership. I think there's ways you could look at that if that was your specific concern.
I mean, I have to answer the question. I've never heard of this advanced birth center entity. And I certainly don't want to, diminish the concern about that. I think that a big for-profit, multi-million-dollar birth center, Vermont is not going to be the place somebody's going to put one of those because there's not the people. I mean, if you're really going to put that much money into it, you're going to need a lot of people coming to that birth center. We don't even have that many people, right? We have 5,000 births a year.
Yeah. If from all over the state too. You can't.
Yeah, right, exactly. I mean, I again, I don't want to minimize the concern, but I think the likelihood of that is quite remote. Yeah.
Daisy.
I understand the transfer portion to be a significant concern, but I think we've heard testimony. I think that's why a particular concern of mine is the capacity of a group of midwives or someone else who is trying to open a birth center, beginning and going through the process of applying for a certificate of need. I feel they would lack the capacity to do that and responding to questions and whatnot. And I'm wondering what your thoughts are on that if we removed the full exemption and just inserted exemption from the transfer portion.
Well, I mean, my own feeling, it's quite a strong feeling, is that we should leave the full exemption in the bill. That's what I would feel, most clear and comfortable with. And I know that it is the feeling of both of the organizations I'm representing. Because of that, because of the issue, it just keeps it clean. And I really, I mean, I would be shocked if there was a birth center in Vermont that met the $11 million threshold. I just don't see it. I just don't see it. Again, I think it's going to be a struggle to open one without the CON. It's not easy. So I guess to me, but this is you guys have to decide what makes sense to you. That's not really a concern that I have. I think my concern is let's not put up any barriers to having birth centers open so that we can actually have a few. Does that make sense? I don't.
Oh, totally.
Okay.
I'm just thinking how do we also protect, Vermonters and birthing people here from things in the future and do this efficiently.
I have a question.
Yeah, can I ask a really quick question? How many midwives do we even have in Vermont? I don't think did you know that?
I don't know that off the top of my head, but I would certainly get that info for you. I mean, we know, so part of that is that we have, we have organizations, but not all midwives are members of the organization. So, I could, not off the top of my head, but I could tell you how many midwives are in the Vermont affiliate. And, that wouldn't necessarily tell you how many practicing midwives, because some of them don't do birth, some of them practice only GYN, some like me are retired, but it's, my guess is, somebody runs off. I'm going to guess 30, 35, something like that. And CPMs.
Is that what you're saying?
Yeah.
That's all?
I don't know. I'm very happy to get that information to you. I'm guessing.
Sorry, I think.
And I think fewer CPMs, and they have an association, but I know, that there is a very active practice down in the Bells Falls area that is not part of the association for whatever reason. I don't know why. But so that, it's unfortunately kind of a little bit of a hard number to get, but I guess we could also, in terms of home birth midwives, go into vital statistics and find out how many midwives are signing birth certificates. That's one way to find out.
Yeah, I was gonna say,
I'm doing it right now.
We're all on.
Okay, great. There you go. You guys.
You have a question?
Yeah, I'm trying, because I can't find it. I think somebody in the testimony told us about how many births there are in Vermont in a year.
52, was it?
Yeah, it's 5,000 something,
Yeah, I got that number.
Oh.
I got that number of births. And then I started thinking about birthing centers.
Uh-huh.
And I said to myself, are we talking about birthing centers with multiple births taking place at once? A lot of them? Or are we talking about a birthing center that has maybe one or two?
Yes.
Happening.
Yeah, that's a good question. I think that, the likelihood would be, this is the likely scenario, would be that a birth center would be serving somewhere between 4 to 8 families a month.
A month.
If you had one in the Burlington area, it could be more than that. For instance, I know the birth center they have down in Northampton, Massachusetts, does about 10 to 15 births a month. But that's quite a lot for a birth center. And, until recently, they were the only birth center in Massachusetts. So they were pulling from Vermont. They're pulling from a lot of places. Massachusetts has decided to really invest in it. They're actually, they're providing funds for people to open birth centers in Massachusetts. So anyway, so I think in Vermont, my guess is going to be 4 to 8 families in almost any birth center you'd see. Yeah.
Alan, did you have a question?
Well, I don't know a thing about this stuff, okay?
Okay.
But when you're talking 8, 10 a month, how are you folks gonna stay open?
Because the costs are lower and people are willing to.
Well, that's true, the costs are lower, but you've got electricity, you've got taxes, you've got, everything goes with it, you got staff.
Right.
It don't compute with me where
Right.
you're gonna make a living.
Well, so here's one of the things to understand about birth centers. For instance, the people who work at the birth centers, the providers, they don't stay there. So you're not staffing that birth center 24/7. They come there when there's somebody in labor. Okay. So, you can have a birth center that has 2 midwives and, whatever, 3 or 4 assistants. We're not talking about a huge staff. People, quite honestly, who work in birth centers are often willing to work for less money than they would make in the hospital.
Okay, and if somebody's gonna be on staff, are they licensed to, if somebody is having issues, can you give prescriptions out of the birth center, or do they?
So there's going to be, in the rules and regs, there will be a formulary, right? For what medications have to be on site. And those are going to be things like anti-hemorrhage medications, the routine medications for the baby, vitamin K and eye ointment, maybe something like epinephrine, So routine things for the baby and emergency things for the mom, okay?
And low risk pregnancy.
Right. If you have, you know, when you have nurse midwives working in the birth center, we have full prescriptive rights. So, you know, after the birth, if I'm working at a birth center after the birth, if somebody wants birth control pills, I can prescribe them the birth control pills. You know, that's just me writing it on the script, handing it to them, their pharmacy, or putting it in the computer, of course, nowadays. So, yeah, so that's how that's going to work. And for the CPMs, it'll be a little different, but they'll definitely have the capacity for all of the emergency things that are most important for them to have. Does that answer your question? Yeah, okay.
If you want, if you include the title.
Oh, okay.
That's the license, certified nurse midwives, there's another 120.
Oh,
Okay.
that's what I was,
With active license.
I was trying to get into the nursing and there's.
120, boy, did I
But
underestimate.
not enough.
That feels better to me.
Yeah, no, I'm thinking, I'm visualizing like the mailing list when I, you know, when I send it out to the affiliate, but maybe obviously didn't get that right.
I mean, yeah, go ahead.
I like what our legislative council just said something, and I didn't hear it all.
Oh, she was telling us how many midwives and certified nurse midwives there are licensed in the state.
And my question then is because you mentioned medication.
Yeah.
Nurse midwives, are they licensed to administer
Yes,
medication
correct. And prescribe.
and prescribe?
And prescribe. And CPMs are licensed to administer emergency medications to the mother. Yeah.
Daisy?
Just want to point out, you've stopped calling me Mari.
You know why? No, I know where I'm. The reason is because, I don't know if anyone's noticed, Daisy has daisies on her sweater today. So every time I look over, I'm reminded, it's Daisy.
Giant and tiny. I know that about 1 in 4 women experience postpartum depression.
Mhm.
As well as, what is it called? Prepartum, like, I don't know what that's called. So perinatal depression.
Yeah.
And nurse midwives can prescribe antidepressants, right?
That is correct.
So you can't underscore enough the importance of this being just an important access point for birthing people to mental health care as well, especially at a time when it's almost impossible to get access to mental health care, even through a primary physician. So I just want to lift that point up.
Yeah, and I would say that kind of highlights the postpartum care that people get that's been spoken of. And that screening, and even if you have a CPM doing that screening and, noticing or, discovering that someone is suffering from that midwife is going to find a way, even though she might not be able to prescribe that medication herself, to get help for her. They're going to have their, ways of accessing care for that person. So, yeah.
One last. Go ahead. Yes, go ahead. Do birth centers that you've worked with before in Texas or wherever, do they typically have a network of agencies, organizations that they can do warm handoffs to if somebody gets prescribed a medication like that, like an antidepressant, and they need counseling or someone to sort of manage?
I think that is typical. Yes, I think that's typical. And birth centers also can serve as, a community resource for people, even, pregnant postpartum people who have not given birth there. Like the question that Brian asked in the beginning, like, what happens if nobody's laboring there? Well, there can be postpartum support groups, there can be, birth classes, there can be yoga, prenatal yoga classes, there can be all kinds of, some birth centers actually have, therapists working there, or at least a therapist that might come in there to help with any mental health concerns that clients have. So I think that it is this nice, they tend to be this nice wraparound kind of service. And I think that's a benefit to them, yeah.
Yes.
I have a statement.
Yeah.
Because it's been talked about a lot and I think it's been swept under the rug a little bit too. If this is going to, if it's going to be a nonprofit or a profit-making enterprise, when we make the statements, these people are willing to work for lower wages, et cetera. Somebody's going to have to build this place or renovate some space. That's going to cost money.
Oh, yeah.
And having heard some of the discussions we've heard over the last couple of days about private equity people or companies, they pay their staff pretty high. So I'm trying to, in my mind now, when we first get into this, I was thinking of a place being built. You can go to Huntington Homes or any place like that. You can get a beautiful place built to do these kinds of things with kitchen facilities, everything for about $300,000 or $400,000, and you put it on a lot. So I don't. I'm trying to judge in my mind, what kind of a place are we talking about here?
Yeah, well, I think I can address it from the standpoint of like the people I know who have started birth centers.
Yeah.
They have, looked for people to invest in the birth center, people who will invest in it because they believe in it, not because they think they're going to get a lot of money, because they won't, or they raise money through family and friends, or, it's, again, the opening of this, is a labor of love. And that's why for most people coming up with that initial $300,000, $400,000 to renovate and equip a place, the ones that I know of, like in New Hampshire, they weren't built from scratch. They were places that were renovated to accommodate what the facility needed. Right. It's a challenge, but again, people do it. And it's done, all over the country.
May I just throw a reminder that this bill is an entire piece on the Vermont Department of Health licensing fees, which would mean that they would meet all the requirements, any other type of health center that is being opened. Sometimes I think as we take testimony, we get caught up in things like the CON process and we forget that the bill as a whole. And I think sometimes we start going down these rabbit holes and we forget that there are some guardrails that are in the bill. This is, these will be inspected, licensed by the Department of Health, who already licenses and inspects and ensures that the healthcare facilities that all Vermonters have are safe and clean and appropriate for the services that are provided there. Anyways, I'm sorry to interject. Any questions? Woody?
Yes, I'm curious. What does it cost to have a child in a birth center? What's the average cost, as well as the doula? What is it? What is the going price for something like that?
So in terms of the birth center, we have Blue Cross Blue Shield information right here.
Okay. So it is the freestanding?
Yeah, so that's the freestanding. That would be $2,870. Now that I believe is sort of the optimal facility fee. Okay.
When I saw that, it just seemed a little high to me.
It seems high.
I thought anyways, but
$30,000.
Yeah, well, so the 30,000, so just understanding these fees, when you have a baby, there's a fee for the provider care and there's a fee for the facility care. Okay, so that's why a home birth is less expensive because there's no facility fee. You just pay the provider. Okay, so these fees are the facility fees. So the hospital fee covers, the food, the nursing care, the, various things of that nature, the cost of the room, that doesn't necessarily cover the provider fees, which would be like, say you get anesthesia, there's a pretty, hefty little anesthesia fee that you're going to get. But in terms of the birth center, and then there's going to be a provider fee for what we call global care, which is prenatal, interpartum and postpartum care. And typically, that varies. If you're getting reimbursed by Medicaid, if you're getting reimbursed by, Blue Cross Blue Shield, I would love to be able to tell you an exact number, but it would be the same for the midwife who works in the hospital, the midwife that works at the birth center, and the midwife that works at home. It's going to be the same amount of money.
$1,949 and change.
Thank you.
Looked it up a minute ago.
Okay. So then there's that. Yeah.
And you have a contract with the patient before they're admitted, I guess?
Yeah, sure. Yeah. As Rebecca was talking about there, I think the people are very well informed about all aspects of their care, going through the process. Do you want me to move to transfer sorry.
I'm interested in.
Oh, yeah, right. I'm sorry. Excuse me.
Most doulas that I know are self-employed. I know that most of them labor of love, use a sliding scale. For what we are doing and what our servicing contract would be with the client, we are $2,000. And that is a team of 2 doulas from when the second you sign on, all the way through postpartum care. So that continuity of care is all the way through. We show up at a labor. The labor can be 20 hours. We don't leave. But it's 2,000. That's it. It doesn't go over that. And I also know that a lot of our clients more and more are actually getting reimbursement plans from their work.
Okay.
Yeah, for benefits. So that's opening up the clientele that we can receive.
But $2,000 through that period of time.
Yeah.
It really is a labor of love.
Yes, it is.
Correct.
Yep.
Transfers.
So let me just read. So what we have now, and I think this was read, but just to refresh our memories, in the statute as written at this point, it says a requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital if circumstances warrant. So that is in the statute. The CPM statute says, this is just a part of it, for something, a guideline, a written practice guideline for transport of a woman to an appropriate obstetrical department or patient care area. So quite honestly, they sound kind of the same to me. I think that the question of I think that the statement about a hospital would have to receive a transport was a little bit misunderstood, because the comment about throwing somebody in a van and taking them to emergency room, that's a little unfair in my mind. I think that is not what was being referred to. But the statute does require it. Now, requiring an agreement with EMS that might be relevant for emergent situations. So I want to really refresh everyone's memory about 10% transfer rate, 2% emergent. Okay, so 2% of the 10%. So it's very small. I will say that, when I did home births, which I did for 25 years, I did over 1,000 home births in that time. I had a transfer rate of 8%. So 8% of the time people were transferred during their labor to the hospital. I had 4 emergent transports where I needed to call an ambulance and get somebody there as fast as I could. 4 in 25 years. So it is a rare circumstance, and it's rare because of what we talked about in the beginning of my testimony, that, you have this good risk screening, and that goes on not just in the prenatal care, but in the interpartum care as well. That said, it's very important to be able to do that when you need to do it, you know? So, you know, I think that it is very typical that a birth center will have, you know, talk to the EMS people in their community, you know, talk to the hospitals, you know, in their community. I know when the Hanover Birth Center was opened by a Vermont midwife, because she couldn't open one in Vermont, you know, Dr. Fisher was working at Dartmouth at the time, and they worked together, you know, to create all of these, you know, sort of agreements about it, but they weren't written and they weren't required, and they had a willing party, you know. So I think, you know, Dr. Fisher himself said, you know, we shouldn't require, you know, a written agreement between them, but they, you know, a birth center has to have, and the AABC also says this, written guidelines for what they want to do when they transfer a patient to the hospital. When you have a non-emergent transfer, most of the time it's going to look like what it looks like when somebody planning to go to the hospital goes to the hospital anyway. You know, people, you know, unless they're in advanced labor, sometimes people get, you know, caught up and they're, you know, everything's going very quickly and they call the ambulance to go to the hospital. But most people, when they go into the hospital, have a baby, get in their car and go to the hospital, right? And that, you know, that is a common thing, I think, with birth centers also. I mean, Lindsay has told me that the birth center she worked at in Connecticut did it that way. Certainly when I was working in Texas, we did it that way. Even, you know, in Mandeville, they do that from Copley at times. You know, if they have a person that comes in and, you know, for whatever reason risks out, but is not in, you know, an emergent situation, that person gets in their car and they go to UVM. You know, so I think that it's just good to kind of, you know, I think we think, oh my gosh, a transfer, there's all this crazy stuff going on. It has to happen as quickly as possible. And that can happen, but it is quite rare. And in terms of your question about the distance, you know, I believe that most people opening a birth center are not going to want to be remote from a hospital. I think dictating it, the distance in statute or even rules, is not advisable for the reason that, you know, Shayla was talking about yesterday, which is that that's not really there's no evidence that that is what creates safety. So I don't know, that's my answer. Does it answer your question?
Yeah, it answers my question. I'll be very honest, I sure as hell wouldn't want to date with my wife. She was having a baby in a birthing center. And something went wrong. And one or the other was lost. That's what my concern was, like I mentioned. You know, if something really goes wrong that you haven't planned for.
And that's
not close enough to the resource that can handle that. That's what
you know, and that's not, I can't sit here and tell you that never will happen or that it never has happened. The only thing that I can tell you is that, yeah, there probably is that small additional risk to being remote from the hospital. However, you know, the risk of being in the hospital, which nobody ever thinks about, somehow counters that in the data, you know? So it's not that one person wouldn't have been better off in the hospital. There probably are people who gave birth at home or in the birthing center that would have been better off in the hospital. But you've also got this whole cadre of people giving birth in the hospital that would be better off.
And I get that.
In a birth center. You know,
I get that. I get that.
Yeah. No, and I hear what you're saying. Of course you would feel.
I know we're talking about going through an assessment center, survey and all that kind of stuff.
Yeah.
And the person who's gonna be there is probably not gonna be at huge risk. So I'm all for that stuff.
Yeah.
I'm just sitting here listening and
Yeah.
I'm putting myself in that
Yeah,
place.
I understand. Yeah.
So,
Yeah.
I don't wanna make that happen.
Does anyone have any more questions? I am tired.
Yeah.
And I'm seriously starting to get very frustrated and I'd like to end committee for the week. So we can go off of live.